contributions. Okay, and so the first presentation is from Jordan Fuzi, and we need 10 minutes presentation and 5 minutes for questions, and we'll go on from there. Jordan.
Thank you, Professor Zagami. All righty, let's get started. So thank you very much for having me today. We're going to be talking about the tertiary level management of pediatric acute invasive fungal sinusitis. And this is on behalf of myself and Dr. Katrin Banks. I'd just like to say thank you to the Departments of Infectious Diseases, Pediatric Hematology and Oncology, and Anatomical Pathology for their input in these cases. So acute invasive fungal sinusitis, it's an aggressive fungal infection of the sinuses that is characterized by invasion of the mucosa of the nose and also the blood vessels, and it results in gross necrosis of the mucosa. It's rapidly progressive, it is an aggressive disease, and it is associated with significantly poor mortality. And the numbers on the right are from the one large aggregation of cases, 103 patients. You can see that the overall survival rate is approximately 55%. So who gets this? It's predominantly an infection of the immunocompromised. 90% of the patients in the pediatric population have a hematological malignancy, most commonly ALL. It occurs in high-risk patients, those who have been neutrophilic for some time, as well as who have been on prednisone or high-dose steroids for more than 30 days. And on the right is the results of a study where they tried to risk stratify which patients are at highest risk. Those that have had prolonged fevers, febrile neutropenia, and low neutrophil counts are at highest risk. And they managed to stratify these patients into low, medium, and high risk based on those features. It's predominantly an infection of Aspergillus, but you can have other fungi such as mucor and other molds that can cause it. And it's a highly lethal condition. So even with treatment, the overall mortality rate is somewhere between 40 and 50%. The only consistent positive predictor for survival was early diagnosis and treatment, and time or a delay between diagnosis and surgery was found to be a significant risk factor for all-cause mortality. It's difficult to manage these patients as they present in such a non-specific manner. They usually might present with nasal congestion, rhinorrhea, nasal crusting, facial pain, or even no symptoms whatsoever. And so a high degree of suspicion needs to be held for these patients. We have two cases that we've recently treated. The first is a 17-year-old lady that had had 2 prior rounds of chemotherapy, had had at least 35 days of neutropenia, and was persistently febrile for over a week. She had quite classic symptoms of headaches, sinus pain, and coryza and rhinorrhea, and had a CT which showed patchy changes in her sinuses bilaterally. The other patient was a 16-year-old young lady who'd been neutropenic for over 22 days, had fevers for 8 days, and while she'd had some vague intermittent nasal pain, by the time we saw her, she was entirely asymptomatic, aside from a CT showing some mild left sinusitis. And this is where we rely on bedside nasoendoscopy, and that's why we advocate for early ENT consult in these patients. We might find nothing, and that does not exclude an invasive disease, but some concerning findings include edema of the nasal mucosa, or even pallor and necrosis of the nasal mucosa. And this is the nasoendoscopy of the first patient. Love that it says it's not available. I'll show you the second one. As you can see, there is eschar of the right inferior turbinate. You have an ulcerated lesion of the nasal septum. If I go through to the middle turbinate, there's clear necrosis and eschar of the head of the middle turbinate. And this is quite pathognomonic, but we rarely see this in patients. Normally they have normal nasoendoscopy. Whilst imaging is important and MRI is the gold standard, it's often a delay and results in delays in treatment. CTs are helpful both for diagnosis and also surgical planning. A normal CT is often, it does have a high sensitivity and negative predictive value, but you most commonly will just see patchy sinus disease. As the disease progresses, you might see erosion of the bone, and you might even see infiltration into the surrounding structures. This is an MRI showing a pathognomonic black turbinate sign. We have gross necrosis of the middle turbinate. We rarely see that in true practice. The diagnosis result is centered on biopsy and histopathology, and you see gross fungal elements. So this is actually the pathological slide for case 1, and you can see invasion of the mucosa by fungal species and these classic fruiting bodies. Now, we usually will biopsy changes, but sometimes you might not see any changes in the nose, in which case we try and biopsy the nasal corridor, but rapid identification is imperative. For these histopathological biopsies can take up to 3 days, to return. And as such, we're now heavily relying on frozen section analysis. And this is where we can send the specimen to the pathologist and get a result in 20 minutes. The new SCHN approach is to undertake frozen section analysis at the time of initial biopsy. This often requires us calling the pathology lab beforehand and coming up with a plan, as this often happens after hours. It relies on PAS and silver staining and can rapidly identify fungal elements with relatively high specificity and positive predictive value. This can give us an answer in 20 minutes, and it's vital both for diagnosis and surgical management in a timely fashion. The treatment is a multidisciplinary approach. We rely on infectious diseases for antifungal therapy and also the other physicians for reversal of underlying immunodeficiencies, whether this is correction of glycemic control, reversal of neutropenia, or rationalization of immunosuppressants. But surgery is one of the few independent positive predictive factors or prognostic factors for survival. It results in an early diagnosis, improves antifungal delivery, and can reduce fungal burden. But this is where the dual benefit of frozen section arises from. Firstly, it can give us a rapid diagnosis, but also can help us with our extent of surgery. We classically would just debride until we had bleeding tissue and no visible macroscopic disease. We now heavily rely on frozen section to complement this. We evaluate the margins in a very specific tumor-like approach, where we biopsy and map areas of the nose, and that we can firstly find if we've had a gross surgical resection, but also know that if something comes back positive later, we know which area to attack. And the reason is, this is from the first case again. The video is not playing, but we had resected to gross positive or gross bleeding tissue with a different surgeon, and all those margins ended up coming back positive. So we rely heavily on using frozen sections now to identify our negative margins. One study evaluated the usefulness of this. They demonstrated a survival rate of 95% with complete surgical resection using frozen sections, as opposed to 42% in those where they did not receive complete surgical resection. And whilst those numbers probably somewhat relate to the complete resection being a result of lower disease burden, the overall survival in this cohort was 69%. A similar study also showed an overall survival of 69%, utilizing frozen sections as both as an early diagnostic measure, but also a surgical resection guidance. And that is well above the general standard survival rate. Now, these slides were created by our infectious diseases colleague. For these patients, as soon as there's suspicion for fungal disease, need to be started on antifungal therapy. And the empiric therapy is guided by a number of different factors: the suspected organism, the sites of infection, any drug interactions, and also the patient's other comorbidities. And we are guided by the Australian consensus. But there's a few. We either will usually start with either liposomal amphotericin B or voriconazole, and they have their relative benefits and cons. Now, postoperative surveillance is highly important. We see these patients twice a day for the first week, and we're looking at both disease monitoring, but also management of their postoperative crusting and disease. And we do usually take these patients back to surgery at 48 hours afterwards. We now are heavily relying on an endo suite, which is a new model of care that I'll talk about in a moment, that allows for these patients to have their monitoring done in a less invasive model that results in a quicker post-anesthetic retirement and a more pleasant experience for the patient. This is a suggested management algorithm. It's quite complex, but we're heavily focusing on the use of frozen sections to guide our immediate resection at the time of diagnosis. And this has resulted in a significant avoidance of delays to diagnosis and treatment. They also require return to theatres for further biopsies and monitoring at 48 hours, which can be performed in this endosuite model. So this is a new model of care that we've instituted this year at Sydney Children's Hospital, and plan on increasing its use widely amongst other specialties. We've used it in 23 patients thus far, and overall had an overwhelmingly positive experience, whereby patients receive sedation, not anesthesia. They don't need to be intubated. They wake up less anxious, less groggy, and have a much lower time in surgery. They often only end up staying in the hospital for 3 hours, opposed to 6 to 8 hours. And overall, we've doubled our case numbers by using this endosuite model of care. And I just wanted to play a short video of our first patient with the fungal disease. Just my references.
Thank you very much for that. Could I just ask what your involvement was with the case and pardon? Not you, Sandrino, the speaker.
Our involvement was undertaking the surgical debridement of their fungal disease and then the multiple follow-ups needed to biopsy and debride their noses.
That was great, thanks. So you said you had 23 patients. Did they all actually have this, or were there 23 patients in whom it was suspected?
Those are 23 patients who underwent endosuite for a number of different reasons, all for sinonasal procedures. A significant proportion of them are actually cystic fibrosis patients who need repeated nasal debridements, but it's for any patient who needs a minor operation that can be done without an ETT and can be done in more of a sedation model.
Very nice. So now, can I just go back to the idea of the fungal?
Mm.
So would we be doing this now for all the people? You said some of them are asymptomatic. So all the people with fungal suspected fungal or proven fungal septicemia?
Mm.
And would we be doing this, looking in their nose, for all the people who we think has fungus in their brain?
Not necessarily. So as I showed on an earlier slide, we risk stratify them. So some patients are asymptomatic, but in a combination of the symptoms, the degree of neutropenia and fevers, as well as
in neutropenic people,
yeah,
and fungal sepsis.
Sorry, the duration of neutropenia, but based on the signs, symptoms, our nasal endoscopic findings and CT findings, if we have any sort of suspicion, we will take those patients to theatre and biopsy their nose that night.
And in a week or a day or a year, how many would we do here?
How many do we do? So this year,
for fungal.
this year we've had 2 confirmed cases and we've taken a further 3 to theatre for biopsy that came back negative.
Excellent. Thank you.
Sorry, I was going to ask a similar question.
Hey, Zoe.
I was just wondering, I was going to ask a similar question. It was a great presentation. Does age affect that as well? Like if it's a smaller child, or is there a particular age with the fungal sinus? I'm just thinking for coming from theatres myself, with the age group for that, would that model still work for a younger age group, or are you not experiencing it for that group?
As in the endosuite model?
Yes. Sorry.
Yeah, so the majority of our patients that we do endosuite are those who can't tolerate in clinic procedures. So they usually are anywhere from 2 up.
Thank you.
Thank you.
Hello everyone, I'm Holly Campbell. I'm one of the paediatric surgical trainees, and today I'm presenting on our early experience with indocyanine green near-infrared fluorescence in our paediatric surgical patients. I'm presenting on behalf of the department and on behalf of Dr. Dylan Wanaguru. So in terms of a brief overview, what is ICG and how is it used? ICG is a water-soluble compound that absorbs near-infrared light with a peak absorption at 800 nanometers. The key characteristics are that it binds rapidly to plasma proteins, it has unaltered biliary excretion, it's sensitive for unidirectional lymphatic mapping, and it's broadly a safe compound to use. So ICG fluorescence guided surgery uses a combination of ICG delivery and fluoroscopy to assess vascular, lymphatic, and biliary structures intraoperatively. It is a technology that has established use in adult cohorts, but we don't yet have established use in paediatric surgical cohorts. So through the ages, ICG has been used for a variety of, purposes in healthcare. So it initially was used in the 50s for assessment of cardiac and hepatic function, just by looking at intravascular concentrations and clearance. The fluorescence properties were established by ophthalmologists in the 1970s, and at that point in time, the technology was limited by the fluorescence aspect of it. There were improvements in the 90s that led to us being able to use the ICG fluorescence angiography in the way that we do today. And in the current day, we have specifically established the angiography component of it in a lot of different adult populations. It has, I guess, its greatest use in colorectal anastomoses, lymphography for sentinel node detection in malignancies, and also for vascular assessment of grafts and flaps in reconstructive surgery. A brief literature review. There are good systematic reviews in adult cohorts that demonstrate that there is a decreased rate of anastomotic leak when ICG fluorescence angiography is used. As secondary outcome measures, admission cost and length of stay are also reproducibly decreased in groups that are treated with ICG. In terms of the paediatric surgical cohorts, there are a few systematic reviews, most of which have been published in the last few years, but I guess their interpretation and their application is limited in the ability, I guess, in the sense that they don't use the same primary and secondary outcome measures. And they look at parameters like change in operative plan. And I think while that's really useful in that it tells us that ICG does change the way we operate, it doesn't allow us to standardize the impact of ICG on our intraoperative decision-making. And it's really hard for us to establish, I guess, how we use ICG across different centers and across different parts of the world. So I think it's important for us to recognize the utility of this technology and I guess look at ways to implement more robust research that allows our practice to be guided. In terms of why ICG guided fluorescent surgery is good for pediatric surgery, I think we deal in general with a difficult cohort. So cohort factors that are relevant are that it's really difficult for us to assess the vascularity of our patients preoperatively. So in adult cohorts, we can do things like vascular assessment using CT angiography or CTAs that we can't do in our patients. We also have pathologies that present with non-anatomic patterns of ischemia, like our neonates who get NEC. We are limited in our tactile assessment of perfusion. It's really difficult to feel pulses in the mesentery of a, sub 1 kilo baby. And our cohort is also subject to more congenital variation than most. I think in peds, we also feel as well that our patient population has less reserve. They're usually a bit less robust. And so our complications have more significant outcomes. In terms of procedure factors, we're often in a situation where there's a greater need to maximize the viable organ or tissue. So in terms of things like preserving as much gut length as possible, that's something that operatively is a really big consideration for us. The rapidity of how ICG is used is really beneficial because it means we can not significantly extend the time of our general anesthetics or our operative time. So I guess looking at how it can be used, it seems highly relevant to a cohort of paediatric surgical patients. Our experience in this department at Sydney Children's Hospital is quite broad, considering it's something that we've only started using recently. So in terms of assessing the gastrointestinal tract, we've used it for cases of NEC, complex gastroschises, Hirschsprung's anastomoses, gastric tube formations, and esophageal anastomoses. We've used it for lobectomies, nephrectomies, and heminephrectomies. We've used it to assess lymphatics in a child that had a chyle leak post-neuroblastoma resection, and we've used it to assess the biliary tree during laparoscopic cholecystectomies as well. In terms of our experience, our protocol is quite varied. Our dosing is anywhere between 0.05 and 0.5 milligrams per kilogram, and the way that we administer it depends on what variable we're looking at. So if we're looking at angiography or we're looking at the vascular assessment, we give it intraoperatively a few minutes before or kind of at the time that we feel we're going to need it. For lymphography, so for the patient with the chyle leak, we gave it it took about 10 to 15 minutes before we were able to visualize the structures of interest. And for assessment of the biliary tree, standard protocols in peds tend to give it kind of anywhere between 15 and 30 hours before. So we gave it to our patient 20 hours before. We use the Stryker as well as the Karl Storz instrument and the software. So we use a handheld instrument and we also use the laparoscopy or the thoracoscopy instruments as well. There's a few different modes that we use intraoperatively, and this is I guess these are the three main ones, but the videos that I'll be showing today are all in the SPY overlay mode. So this is a video that demonstrates how we use ICG to assess an anastomosis in a patient with Hirschsprung's disease. So you could see at the start that the tissue looked like normal bowel tissue to the naked eye. And that's what it looks like if you're looking at it without the fluorescent software on. So just again, at the very start, we're looking at bowel tissue, and then we've given the ICG intravenously, and then we turn on the fluorescent software. Our second case looks at the perfusion of a lung. So we have a congenitally aberrant anatomy, and we were able to use ICG to make sure that we could safely proceed with the lobectomy despite aberrant anatomy. And then in our third case, we use ICG to demonstrate a lymph leak in a patient that had chylosociety post-laparotomy and resection of neuroblastoma. So in summary, we think that this technology is highly relevant to a cohort of paediatric surgical patients. We think it helps us make nuanced clinical decisions in a patient-centric way. The technology is safe, pretty cheap, and easy to use, and there's a broad range of applications. The only negative side effects that we have seen is in the patient that we used for lymphography. He did have some temporary green staining of his toes, but that went away after a few weeks. He called them Hulk toes, and he was pretty stoked. These are my references. Does anyone have any questions? Yes?
Hi there, thank you, Prof.
People online, everybody.
Hi, thanks for the talk, that was great. We've used the endobronchially
Yeah.
ICG to help us detect the intersegmental plane in lungs for anatomical segmentectomy. Were you using it intravenously for the lobectomy?
Yes, yeah. So we use it intravenously if we're looking for a vascular assessment, and then we just use it subcutaneously if we're doing a lymphatic assessment. And biliary assessment, we use it IV, but we kind of have a much longer interval between operative use and administration.
Thanks very much. Thanks.
So excellent, really well done. So did you do any of these cases yourself? And how many do we use this on in a year here?
Yeah, so these were pretty big cases. I was involved in them, but I wasn't the primary operator. And in terms of how many things we're using it on at the moment, we've really started using it pretty heavily this year. And anytime that we're doing a case where we think that there's going to be questionable anatomy, or we're doing an anastomosis and we think it would be useful to look at the vascularity of that anastomosis, we tend to use it. We're also using it more in our oncological operations. I guess we're very much still in the phase of almost thinking of, well, where can we use it and how can it help us?
So you're doing like 10 times a year or 100 times a year?
Oh, I think this year alone, we would have used it more than 20 times. Yeah.
Excellent.
Hi everyone, I'm Kat. I'm one of the basic physician trainees at Prince of Wales, and I'm here presenting on behalf of the Prince of Wales Respiratory Department. And I've titled my talk The Great Air Escape for reasons that will hopefully become clear, but we'll see. So I'll start with the case. So if Mr. J, he's a 68-year-old gent, he's from home with his wife, And he's come in with 2 weeks of worsening dyspnea and pleuritic chest pain on a background of an ANCA-positive vasculitis diagnosed over 10 years ago with pulmonary involvement, severe pulmonary fibrosis, COPD, as well as end-stage renal failure secondary to his vasculitis, not for dialysis, ischemic heart disease, hypertension, and treated latent TB. And he's overall a very frail gentleman, even though he's only 68. Whilst he's in hospital, he has a VQ scan because his renal function's a bit naff and shows multiple perfusion deficits that suggest a subacute pulmonary emboli, but it's difficult to interpret due to his parenchymal lung disease. He started on some ivory heparin, things looking good, but unfortunately, he's reviewed on the ward for acutely worsened shortness of breath, as well as a new oxygen requirement. And this is his chest x-ray. Hopefully that projects, but you can see it's got a large apical bulla here and loss of lung markings in the lateral edge, demonstrating a pneumothorax. So he has an ultrasound guided chest drain put in on the ward, and he has an improvement in his pneumothorax, but there's persistent bubbling in his chest drain and it's put on suction. And he developed some subcutaneous emphysema, and this is his chest x-ray the same day. You can see the lung is more expanded, chest drain sitting here, and he's beginning to get some air subcutaneously here, which is not where we want it. So we remove the drain, makes sense. And then he has a new pneumothorax again down the lateral pleural cavity. So a new drain's put in, which partially gets rid of this pneumothorax. And we put a second one in apically with interventional radiology to try and address this pneumothorax and perform what's called a blood patch, which I'll talk about a bit later. So now he's got 2 drains in and there's bubbling coming out of both of them, and the blood patch does nothing. The next day, it's got more and more air under the skin and he's desaturating, so we have to take that drain out. And he has a CT that shows a worsening of his pneumothorax and extensive subcutaneous emphysema, as well as air in the mediastinum, and has a drain put in again. Another blood patch unsuccessful, and he's still got diffuse bubbling coming out of his drain over a week later. So poor Mr. J is full of holes, full of drains, and we're really not winning. He's getting a bit miserable. And this is his CT. I think you can probably tell it's abnormal. So here's a drain sitting in here. This is lung, this is all air, which shouldn't be there. And even more concerningly, he's got lots of subcutaneous emphysema up into the neck, as well as in his mediastinum. And this is the transverse view as well. So it's been about 3 weeks. Mr. J stuck in hospital. He's got 2 drains in, there's bubbles. He just wants to go home. He doesn't want to be tied down by his drains. So what is a persistent air leak? So it occurs when there's a communication between the alveoli and the pleural space. Essentially, you've got air continuously going into the pleural space and coming out of the drain. So the lung itself cannot expand and it doesn't heal. And if it lasts more than 5 to 7 days, that's what we call a persistent air leak. And it's visualized in the bubbles in the drain. It's commonly caused by a spontaneous pneumothorax in someone who has underlying lung disease, or if someone's been mechanically ventilated or had surgery. It's most common. It's most commonly studied in critical care patients, and it's associated with a high mortality and morbidity, as well as a long length of stay. So how do we plug the hole? So historically, would be surgery. Our cardiothoracics colleagues would take a look and hopefully find the hole and sew it back up, I assume. Fluorescence, either chemical or blood patch. You can send a patient home with a valve and a drain in. And endobronchial valves, the topic of this talk, became available in the early 2000s. So just a note on a blood patch. Essentially, it's an early treatment that's been used since the 1980s, and you use the patient's own blood and sterilely sort of shoot it up their drain into the pleural space with a view to clot and sort of help seal the leak in a sort of easy way for the patient. And that was tried for Mr. J twice with no success at this point. So what is an endobronchial valve? So it's a one-way valve that you stick in an airway, and once the air is breathed out of the lung space, the lung collapses and air can't get back in. So basically blocking off that section of lung. And the procedure, so you need to find the leak, size the airway, and then deposit the valve in the right spot. And this is one of the brands of valve. This is a Zephyr valve. So this is a picture of the balloon catheter that's used to size the airway. So essentially the patient has to be intubated and under general anesthetic. You need to have the drain in situ so you can see where the leak's coming. And intubating just allows you to consistently ventilate, and you use the balloon catheter to progressively occlude the smaller airways and find the one that you want to block to get rid of the leak. Obviously, once you've sized the airway, you can use the right size of valve. And then there's the exciting moment of truth where you release the valve into the space and watch your drain to see if the bubbles have gone away. It's all very exciting. So for us, practically, we had someone in theatres watching the drain to see how many bubbles were coming out. And that was me. Biggest achievement to date. Usually about 2 to 3 valves are required to control the leak, but up to 10 have been used. So what's the evidence? There's not a lot of evidence for endobronchial valves for this indication. There's no randomized controlled trials, but there are a small sort of case series, one series of 7 patients who had a leak for over 4 weeks. All of their leaks either resolved or improved greatly after valve placement. A slightly bigger study of 40 patients, the air leak would decrease or resolve in a vast majority of them. Complications, the usual things of infection, the valve can migrate and move, leading ironically a pneumothorax or desaturate. All-cause mortality seems to be around 10%, and that's probably because these patients are very comorbid, not candidates for surgery in the first place. We don't have a lot of data on sort of long-term implications of these valves. So for Mr. J, as you might expect, the cardiothoracic surgery was consulted, and they felt that surgical intervention would be more likely to be harmful than a help. They would have to perform a thoracotomy and ventilate him on his one good lung, which probably wasn't going to be possible. And even if they found the leak, it was felt that his parenchymal lung disease would make it very difficult to fix the leak through suturing or stapling. So as you might suspect, Mr. J scored some valves. So this is the balloon catheter sizing the airway here, and these are the shiny Zephyr valves. So we had 3 valves put in, and the air leak was improving, and his chest veins were subsequently removed. And you might be able to see here, there's no drains and there's no gap. So the lung is up, he's still got this large bulla, but no more pneumothorax. And that's demonstrated again here on the transverse slice of the CT. Still got a bit of subcutaneous emphysema, which was resolving. And in the end, he was discharged home and he made his great escape from hospital. And there's my references.
Sorry if I missed it. How many cases have you actually done it? Right, so it seems like last option surgery, right?
Yes, so I don't think we've done it a lot at Prince of Wales. I think when we did it last year, that was the first time we'd done it here. I think we've done it one other time since then.
And so moving forward, you think it's a good option, obviously, in those cases?
I think so. I think these patients are very frail and it's a last ditch option. For Mr. J, you know, he was either going to die or we could try it and see, and luckily he had a good outcome and he got home for 6 months after this. So I think from my anecdotal experience, it seems like a good option. Yeah.
Thank you. Great presentation.
Thank you.
I'm guessing you went to theatre on that case?
Yes.
That's great. And just, could you just explain to me how that valve works again?
Yes, that's a good question. It's a one-way valve and it will sit in the airway, and essentially the air can come out of the lung space. So when the patient breathes out, the air will come out of the lung
Oh, I
and
see.
then it
One
can't be
way,
breathed in
that's it.
again.
You can't breathe it into that distal
Correct.
part of the lung, but you
Exactly.
can breathe out from there.
Exactly.
Gotcha.
They were originally designed for sort of lung volume reduction for those patients that can't have a lobectomy.
So this question might be more directed to Paul, might have to answer it, but you said that you sequentially occlude the lower airways to try and find the leak.
Mhm.
How hard are you blowing that balloon up? Because I imagine you blow the balloon up, it looks snug, you're still getting an air leak. How do you know that that air leak is not coming from where you're inflating the balloon? And then I guess I have one follow-up question after that.
I'm not sure, I'm not the proceduralist, but Paul might be able to help.
What you'll do is you'll try using radiology to work out where the leak is from. And we spoke at a radiology meeting and they thought that the most likely was that bulla or around that bulla that was the main target. So we went into the subsegments of the right upper lobe and we tried occluding all three of those individually. But when we occluded that balloon, so it's just a small catheter balloon that you inflate either water or saline, either saline or air into. But each subsegment wasn't giving us no bubbling. But when we completely occluded the right upper lobe, the bubbling in the chest drain went away. So we hypothesized that putting valves in all three of those, and probably the reason why you're still getting occlusion, because it's in one of those subsegments, but there's going to be back channeling through the pores of Kohn, through all that area of the right upper lobe, but there was probably an intact fissure, so that if you got collapse of that right upper lobe, then you would be able to isolate the lesion. Does that make sense? Yeah.
How long is the valve last?
Yeah, so look, we do it as a no, it's good. They were designed for lung volume reduction surgery. So we used to chop out emphysematous lung lobes, but that had a high degree of morbidity and mortality. And so it was kind of largely after the NETS trial in 2001 kind of went away. But we then found that we could put these one-way valves in to deflate that. So basically collapse the lobe, and then they would get the same benefits of that. So they would get improvements in their dynamic compliance in the lung, and their diaphragms would improve because they weren't so flattened and they weren't breathing at high tidal volumes. So it's a palliative procedure for people in severe emphysema. So they technically don't last that long as patients. But we've actually shown an improvement in survival in those that get valves compared to those that don't. So long answer to the question was they probably can last between 5 to 10 to 15 years. And we don't see as many infections. A lot of people ask me about infections in these foreign bodies in the lungs, but we don't see as much as the other issue, which is that you can get a pneumothorax because the other part of the lung, the lobe, expands into that, and it's emphysematous as well, and so it can tear, and then you can get a pneumothorax with that part of them. Yeah. Okay, thanks.
Right. We've got a minute to steer back.
All right.
Thank you so much. So my name is Dominic. I'm one of the cardiology advanced trainees, and I've got a case of immune checkpoint inhibitor myocarditis. So before I start, I'd just like to give some acknowledgements to the multitude of people who helped out on this complex case. Special mention to our colleagues over in London, the Barts Heart Centre and University College London, who helped out significantly as this case progressed. So we start with DW, a 41-year-old male who was diagnosed in August of 2020 with a mediastinal mass with metastases to his pleura and skeleton. At that time, it was either a lung primary or thymus primary, and it was commenced on targeted kind of carboplatin pemetrexate and pembrolizumab targeted a lung primary. Unfortunately, progression was noted in March of 2021, and this chemo immunotherapy was stopped, and he subsequently started on a trial multikinase inhibitor in May of 2021. Once again, progression was noted on imaging, and so this was stopped. And it wasn't until September of 2022 when he went on his third line of therapy, another phase 1 trial immunotherapy with a TIGIT-PVERG bispecific, as well as a novel PD-1, PD-L1 axis immunotherapy. As part of the trial, routine safety pathology tests were performed at a weekly basis, and then noted a grade 3 transaminitis on the 15th of November. This was presumed an immunotherapy-related adverse event, and he was commenced on oral steroids. His AST and ALT briefly improved the next day, and the steroids were decreased, but paradoxically, he was subsequently profoundly lethargic and anorexic. And so, as such, he was referred to hospital for further investigation and management, approximately 5 weeks post immune checkpoint inhibitor initiation. At that time, he also complained of subjective neurological disturbances. In ED, he was hemodynamically stable, and his cardiorespiratory and neurological examination was unremarkable. Although, as you can see from the table on the right, he did have an abnormal ALT, AST, as well as creatinine kinase that was over 10 times the upper limit of normal. His ECG was performed, and at that time was reported as sinus rhythm with ventricular bigeminy. And as such, he was admitted to the oncology ward under the oncology team with a plan for further pathology testing, ophthalmology review, and MRI brain given his neurological symptomatology. He was commenced on a proton pump inhibitor and Bactrim PJP prophylaxis in the context of the steroid use, and this whole panel on the right was sent. Now, this wouldn't be a cardiology talk if we didn't have a raised troponin, and certainly that came back markedly elevated at about 150 times the upper limit of normal. And so as such, a transthoracic echocardiogram was expedited in the evening, which I'll show here. For those of you who don't look at these all day, we can see here the left atrium, the left ventricle, the right ventricle, and the aortic valve. And I hope you can appreciate that this left ventricle is markedly desynchronous, and we call this at least moderate left ventricular impairment. This was confirmed on a apical 4 chamber, just looking at it from a slightly different angle. Once again, we have the right atrium, so the left atrium, the left ventricle, the right ventricle, and the right atrium. And once again, you can see that it's impaired with desynchronous contraction. Interestingly, if we look at another angle of the parasternal long axis, you can actually see a mass, which is consistent with his known mediastinal mass, abutting the right ventricle as well as the aorta. Given this finding, he was transferred to the coronary care unit on telemetry and commenced on bisoprolol as an anti-failure medication, as well as increased pulse methylprednisolone for immunosuppression. He was additionally planned for a CT chest to assess for any metastatic cardiac infiltration, given that known mass abutting his right ventricle. Overnight, however, he worsened and had runs of a wide complex tachycardia. Fortunately, the EP fellow on call reviewed both the telemetry as well as his initial admission ECGs and realized that he was actually in bidirectional ventricular tachycardia, quite rare but very malignant tachyarrhythmia. As such, he was commenced on IV amiodarone for rhythm control and bisoprolol was ceased, but he was subsequently hypotensive and had nausea and vomiting with relative bradycardia. It was thought he was potentially having an allergic reaction to the amiodarone, and so this was ceased and he was instead trialed on low-dose metoprolol, but once again became unwell and hypotensive. You can see here another ECG, and if we zoom in a little bit more, what we appreciate is that the green lines are his P waves or atrial contraction marching through, and there's this gap where there's no actual conduction. And we still have a multifocal kind of QRS complex, indicating that this is likely coming from the ventricle and in multiple different places. So we're left with a man with no underlying atrioventricular conduction, also known as complete heart block, who's got a life-sustaining rhythm of bidirectional ventricular tachycardia, which, as I mentioned, is almost kind of always malignant and fatal. Additionally, he managed to get a CT chest in this time, and the known mediastinal mass was evident, as well as masses abutting the right ventricle and the great vessels. And there was concern for venous compression of his upper venous system, which is concerning given that he's got complete heart block and we'd be obviously considering pacemakers. So we've got a 41-year-old male with slowly progressive metastatic malignancy on his third line treatment, another second phase 1 trial immunotherapy, who's got persistent ventricular tachycardia with complete heart block. He's got new moderate left and right ventricular dysfunction, as well as a raised troponin, which is thought to represent checkpoint inhibitor myocarditis, but could also represent direct metastatic infiltration. And those concerns over partial upper venous system obstruction complicated any plans for transvenous pacing. So there's a decision for a novel micro AV pacemaker, which is a leadless pacemaker, which is around the size of a 20-cent coin, which can be inserted via the right femoral vein and left in situ. Additionally, he had increased immunosuppression on the advice of our London colleagues who specialize in cardio-oncology, and this is increased to IV methylprednisolone 1 gram a day. You can see here the micro AV pacemaker snugly in the right ventricle, which was confirmed on this parasternal and so apical four-chamber as well as subcostal view. His ECG demonstrated a nice capture with a paced rhythm evident. So in terms of his progress, his troponin and LFTs, you can see on the right, improved but plateaued, and he had ongoing runs of ventricular tachycardia. As such, a second immunomodulator, mycophenolate, was added in addition to the methylprednisolone. His admission was also complicated by left brachial deep vein thrombosis, for which he was commenced on anticoagulation, as well as the initial question of a myositis with the raised creatinine kinase and myasthenia gravis-like syndrome. And it's known in 10 to 30% of immune checkpoint inhibitor myocarditis that you have an overlap syndrome of all three, and the rheumatology and neurology teams were involved to help provide guidance. The EMG and myasthenia gravis antibodies were negative, but that can be the case in immune checkpoint inhibitor associated adverse events. Despite the steroids and mycophenolate, the troponin was once again increasing, so there was also need for a third agent. And it's at this time that we were really scratching our heads because there's not a lot of evidence to guide this. And our fifth team was then consulted, which was the immunology team. And we came up with the idea of abatacept, which has been trialed, and there's actually an ongoing randomized controlled trial now. Essentially, this works upstream of the PD-1, PD-L1 axis, binding to CD86, and therefore enables kind of quite prompt and relatively robust T-cell inhibition. To give us an idea, we can see here his admission to hospital on oral steroids. When he was increased to IV methylprednisolone, his troponin was raised. It did improve slightly, but because of its plateau, mycophenolate was commenced with little improvement. And it wasn't until abatacept that we really saw a sustained and meaningful decrease. Along with this biochemical improvement, he also improved clinically with improvement in his LV function, as well as decreased runs of ventricular tachycardia, and his intrinsic rate below was a paced rhythm. He was hemologically stable despite the ventricular tachycardia and keen to leave hospital, so he was discharged on day 19 of admission on metoprolol, weaning prednisolone, mycophenolate, and a plan to finish day 14 and day 28 of his abatacept. Over the course of the next 2 months, his LV function continued to improve, his pacing burden decreased, and he actually managed to get over to Tasmania. You can see here he has native conduction return with a sinus rhythm with a left bundle branch block. And very pleasingly, from the oncology perspective, he had a partial tumour response with shrinkage of the mediastinal mass over the course of the 2 months. Indeed, when he was seen in cardiology clinic on the 2nd of May, he'd actually just returned from Fiji, and he was only on mycophenolate and metoprolol with an almost normal troponin. And his patient threshold had reduced from 70 beats a minute to 50 beats a minute. And Dr. Crenny actually caught up with him by a phone yesterday, and he just returned from Disneyland Orlando. So he's actually having a really good quality of life with his 2 young children, which I think just shows the importance of us all working together. And here's just the echocardiogram evidence that his function is improved significantly. And I guess just in closing, because I know we've only got 10 minutes, immunotherapy is a game changer. It really has changed the landscape for our cancer patients, but it has many off-target effects, not only cardiac, but as you can see, neurological and rheumatological as well. And it's really only by working together that we can put a broken heart back together again. So thank you very much for your time. Last case of the day.
There's no women in that photo, so you have to be very careful.
This is
Oh, you were great. You were excellent. The mycophenolate would take a long time to work.
Yes, that's one of the problems with it.
Yeah, so that worked out really well for the patient. Could you just get to why that was all about immunotherapy? I'm a brain doctor, so just why was it all about immunotherapy? Is it the tumor, the mediastinal tumor?
So the mediastinal tumor could have a mass effect, but that mediastinal tumor had been relatively stable over a prolonged period of time. And it was the fact that he had commenced on the immune checkpoint inhibitor about 5 weeks before his presentation, which was very typical, particularly combination immunotherapy, that doubles your rate of immune checkpoint inhibitor myocarditis. And sorry, I know it's a complex case and I only had 10 minutes, so I did have to speed through, sorry. But that essentially it was.
Immune checkpoint myocarditis is your cardiac diagnosis.
Correct. Yeah.
Gotcha.
And the fact that the troponin responded so well to immunomodulators just backs that up, because we didn't do anything really in the short term for the mass. Obviously, it did shrink with the immunotherapy, but yeah. In hindsight, he actually did describe maybe some symptoms with that first pembrolizumab, which is also a PD-1, PD-L1, but not a novel agent that was used in this phase 1 trial. And they've actually now changed the worldwide clinical trial kind of not strategy, but protocol to include troponin as part of the monitoring on the basis of this case. Yeah, we obviously fed it back to them and they said, oh, probably should have been looking at that. We might have picked it up a bit earlier and been able to do something about it before it got to such a drastic stage.
Good job.
So much.